Welcome to the Funnel Effect. Today we're conducting a deep dive into the complex, often really perplexing world of constrictive pericarditis, CP. It's this challenging syndrome where the heart essentially gets encased in a rigid shell. And this deep dive is built entirely around a fantastic, comprehensive review published just this year, 2024, in the Journal of Cardiology. It's authored by C. Barton Gillimbardo, MD, and Brian D. Hoyt, MD.
Yeah, this paper is really essential, I think, for anyone wanting to understand where we are with this condition right now, because like you said, CP has historically been a major diagnostic puzzle. So our mission today is really to unpack this clinical syndrome thoroughly. We want to understand how the pericardium, that sac around the heart, how it becomes scarred, rigid, non-compliant, and how that fundamentally hinders the heart's ability to fill up properly and function.
That rigidity really is the key thing, isn't it? I mean, we've known about this condition for centuries, literally, but it's still incredibly difficult to diagnose because the symptoms, they just look like so many other common types of severe heart failure. You see congestion, fluid overload, but the cause is mechanical, right? Not necessarily a weak muscle.
Exactly. And that's precisely why the review's focus on the new millennium is so spot on. There's this palpable sense of optimism now that just wasn't there, say, 30 or 40 years ago. Back then, a definitive diagnosis often came way too late, sometimes, sadly, only at autopsy. Treatment options were pretty limited. But now we have these, revolutionary high-resolution cardiac imaging techniques.
You're talking about things like advanced echo, cardiac MRI, CMR, and cardiac CT, the CCT scans?
Exactly right. These tools let us actually see the pathology and maybe more importantly, understand the physiology much, much earlier.
Yeah.
And this ability to detect it early is now paired with, frankly, a revolution in therapies too. It's not just automatically a high-risk surgery anymore.
So you mean the newer medicines, the ones that target the inflammation itself?
Yes, things like colchicine, which has become pretty standard now, and for the tougher, more refractory cases, the newer interleukin-1 antagonists, anakinra or rilonacept.
Yeah.
Using these has really introduced this whole idea of precision care, tailoring treatment, and critically, even prevention in some cases. It's a huge shift, moving from thinking of it as just this inevitable mechanical failure needing surgery to potentially seeing it as a reversible inflammatory process. That's profound.
So, okay, if we boil it down, leaving aside the history and the latest tech for a second, the core problem we're really tackling for you, the listener, is still that initial diagnostic challenge. How do you confidently say, okay, this isn't your standard heart failure, it's not restrictive cardiomyopathy, but instead, this is CP? Because diagnosing it relies on spotting these really subtle dynamic changes in how the heart works, changes that happen with every single breath. Getting that differentiation right is everything for modern management. Okay, let's definitely unpack the history. It's actually a brilliant story of how medical understanding builds slowly, piece by piece. We knew the pericardium existed way back thanks to Hippocrates, but it really took until the mid-1700s for Giovanni Battista Morgagni, the great Italian anatomist, to truly connect the dots. He was the first one to link those classic heart failure symptoms with finding a thickened, diseased pericardium during his, groundbreaking autopsies at the time.
Yeah, Morgagni laid down the anatomical foundation. Then, as we move into the early mid-1800s, you had clinicians like Jean-Nicolas Corvisart and Sir Richard Bright starting to notice interesting patterns. They specifically documented this link between patients with advanced kidney disease and the signs of what we now recognize as constrictive pericarditis. People were actively trying to figure out, is this just a heart problem or is it part of something bigger, a systemic illness?
And the name we use today, constrictive pericarditis, that came much later.
Much later, yeah. It was Richard von Voltmann in the 1870s who actually coined that specific term. He formally described the mechanical the constriction of that thickened sac, how it choked off the heart's performance. It was really a formalization of the pathophysiology.
And once they understood the what, the how of fixing it started, the surgical challenge.
Exactly. The early 1900s saw the very first tentative, successful attempts at pericardiectomy actually removing that diseased pericardium. These were the initial efforts at a cure.
But the real physiological understanding, the mechanics we base our diagnosis on today, that really crystallized mid-20th century.
That's right. The 1950s were absolutely crucial. That's when the invasive hemodynamic features, the specific pressure patterns inside the heart chambers measured with catheters were first accurately described. This era also saw the first real drug therapies being tried. Aspirin, steroids initially, then pretty quickly followed by indomethacin and, importantly, colchicine. This established the principle that maybe, just maybe, some forms of acute pericarditis could be managed medically.
Okay, before we dive deeper into what goes wrong, we absolutely have to establish the baseline. What is a healthy pericardium supposed to be doing?
Excellent question. So the pericardium is this two-layered sac. Think of it like, well, two layers. The inner one, the visceral pericardium, it's very thin, just a single layer of cells really, stuck right onto the heart muscle surface, the epicardium. Then there's the outer layer, the parietal pericardium. This one's much tougher. It's a fibrous layer, mostly made of dense collagen, like a strong, durable bag around the heart.
And between these two layers, there's that space, right? The pericardial space.
That's the pericardial space, yeah. Normally, it just contains a tiny amount of fluid, maybe up to 50 milliliters, which is basically an ultrafiltrated plasma. And this fluid isn't just sitting there. It does critical jobs. First, it acts like a lubricant, reducing friction so the heart surface can glide smoothly as it beats. Second, it helps equalize forces gravity, hydrostatic pressure across the heart surface, giving it mechanical stability.
So it's not just a passive bag, it's an active, lubricated, stabilizing sheath.
Precisely. We talk about its function using two main ideas. Pericardial compliance, which is basically how easily the sac stretches or deforms when pressure changes, and pericardial restraint, which is the sort of gentle compressive force it normally exerts. In a healthy state, compliance is high. It easily accommodates normal changes, like when you take a deep breath and more blood comes back to the heart, without really changing the pressure inside the heart much at all.
And this leads right to that critical concept that CP just completely wipes out the pericardial reserve volume.
Yes. This reserve volume is like a little bit of slack in the system. It's the extra space available to handle those normal everyday variations in how much blood is filling the ventricles, like when you stand up or take that deep breath. It's the difference between the volume the sac holds when it's totally relaxed and the actual volume of the heart at any given moment. When constriction develops, that rigid fibrotic pericardium just eliminates this reserve entirely. The heart gets stuck inside a fixed, non-stretching container. So now we shift from normal to abnormal. In CP, that nice, compliant protective sac transforms. It becomes thickened, scarred, often stuck down, adherent, and totally non-compliant. The literature often uses the word entombed, and it's quite fitting because the heart is essentially trapped. It's fixed, and it's shielded from the normal pressure swings happening in the chest cavity around it.
And if the heart is trapped in this rigid box, then the total volume inside that box must be fixed instantaneously. That has to mess up function right away.
Oh, absolutely. Eliminating that pericardial reserve capacity leads directly to severe diastolic dysfunction problems with filling. Since the rigid pericardium sets the absolute upper limit on heart volume, it drastically limits how much the ventricles can fill, especially in mid to late diastole. Imagine, like you said, trying to inflate a balloon inside a totally rigid box. It can only expand so far, no matter how much air you try to push in.
So what happens when the blood tries to rush in during diastole?
Well, initially in early diastole, the blood fills the ventricles really fast because the pressure difference between the atria and ventricles is high. But the moment the expanding ventricle walls hit that unyielding pericardial constraint, filling just stops abruptly. That sudden premature halt to filling, even though there's still more blood trying to get in from the veins, that's the functional core of constrictive pericarditis.
And that physical stopping point must have a huge knock-on effect on the pressures inside the heart chambers.
Massive effect. Because the volume is fixed, over time, the diastolic pressures, the pressures during filling in all four chambers, right atrium, right ventricle, left ventricle, they all start to rise. And crucially, they tend to equalize. They all end up at roughly the same elevated level. This equalization of diastolic pressures is one of the absolute classic hemodynamic hallmarks of CP.
Okay, we've got the rigid container, but now comes the part that's just physiologically fascinating, the interplay between the two ventricles, that ventricular interdependence.
Right, because the total volume inside that rigid sac is fixed, the right and left ventricles are basically locked in this constant mechanical competition for space. If the right ventricle manages to fill with a bit more blood, it can only do so by physically bulging the interventricular septum, the wall between them, over into the left ventricle. This directly compromises the space available for the left ventricle to fill. It becomes a kind of zero-sum game for volume between the two sides.
And this competition, this interdependence, is most dramatically exposed by just breathing in and out.
Exactly. In a healthy person, when you breathe in or out, the changes in pressure inside your chest cavity, the intrathoracic pressure, are transmitted pretty much equally to both the right and left sides of the heart. But in CP, that rigid pericardium acts like a shield. It isolates the heart from those external chest pressure changes. This leads to what we call a dissociation of pressures, and it means the simple act of breathing causes these wild swings in how the ventricles fill.
Okay, let's walk through inspiration. We breathe in, negative pressure in the chest normally pulls more blood back to the right heart.
That part still happens, yes. More blood returns to the right atrium and ventricle, but the left side immediately suffers. Because of the fixed total volume and that pressure dissociation, the normal drop in chest pressure during inspiration doesn't get transmitted effectively to the pulmonary veins feeding the left atrium. So the pressure gradient driving blood from the lungs into the left atrium actually decreases. This delays the mitral valve opening and reduces the speed of blood flow into the left ventricle. End result: smaller left ventricular LV filling volumes during inspiration. At the exact same time, the increased venous return successfully increases right ventricular RV filling.
So the RV bulks up, forces the septum over, squashing the LV's available space.
Precisely. And what you see on an echocardiogram is this dramatic inspiratory leftward shift of the ventricular septum. That's the defining echo sign of constriction in action. The volume gained by the RV is literally volume stolen from the LV. Then, during expiration, the exact opposite happens. Intrathoracic pressure rises, LV filling improves, RV filling decreases, and the septum bows back to the right. This dramatic breath-by-breath septal dance is the mechanical signature we're hunting for.
Okay, let's connect these really profound mechanical problems back to the patient. What symptoms do they actually experience?
The symptoms are overwhelmingly those of systemic venous congestion. Think right-sided heart failure. When the atrial pressures start getting up above, say, 10 millimeters of mercury, you start seeing the consequences. Peripheral edema, especially in the lower extremities, fluid backing up into the liver, causing what we call congestive hepatopathy, and ascites, which is fluid building up in the abdomen.
And if the constriction gets worse, pressures go even higher, what changes then?
Once those diastolic pressures climb to 18 millimeter Hg or more, patients usually report significant functional limits. They get exertional dyspnea, shortness of breath when they try to do anything, and orthopnea, meaning they can't breathe comfortably lying flat. Pleural effusions, fluid around the lungs, also tend to become more noticeable at this stage.
And that late-stage decline leading to cardiac cachexia, that sounds devastating.
It truly is. It represents the ultimate systemic consequence of the mechanical failure. When the heart's ability to pump blood even at rest, the resting cardiac output declines drastically in the late stages, patients develop this syndrome called cardiac cachexia. It's marked by just profound lethargy, exhaustion, severe early satiety. They feel full almost immediately after starting to eat because of the liver congestion and gut issues, and rapid, diffuse muscle wasting. It signifies a body that's essentially starving because the mechanical straitjacket on the heart prevents it from delivering enough blood flow, no matter how strong the heart muscle itself might be.
Okay, let's shift gears a bit and talk about what actually causes this. The etiology of CP is really interesting because it varies so much depending on where you are in the world. In developed countries like the US or Europe, the most common causes we see are, well, idiopathic, meaning we don't know the exact cause, maybe presumed viral, or it's a consequence of previous cardiac surgery, or radiotherapy to the chest.
That's right. But if you look worldwide, the picture is completely dominated by infectious disease. The single biggest cause of constrictive pericarditis globally is tuberculous pericarditis, TB. This difference really highlights the huge and often preventable burden of CP in parts of the world where tuberculosis is still endemic.
The source material actually gives some pretty striking numbers on risk stratification. How likely different types of acute pericarditis are to progress to chronic constriction.
Yeah, the data is quite stark. The absolute highest risk comes after purulent pericarditis. That's a bacterial infection in the pericardial space. The progression rate there is staggering, something like 52 or 53 cases of CP per 1,000 person years of follow-up. Tuberculous pericarditis isn't far behind, around 31 or 32 cases per 1,000 person years.
Wow. Those numbers really drive home how quickly intense inflammation and infection can lay down permanent, scarring collagen.
Absolutely. They're orders of magnitude higher than, say, the risk after pericarditis following a heart attack. But the flip side, the good news, is in the data for the most common type in developed countries, idiopathic or viral acute pericarditis. The risk of progressing to CP there is actually quite low, less than 1 case per 1,000 person years. If, and this is the key part, if it's treated properly according to guidelines. This is why getting that initial medical therapy right is so vital now. It's basically become a prevention strategy for chronic CP.
So let's detail those prevention strategies. What are the modern ways we try to stop CP from developing in the first place?
Well, it really starts with aggressive, guideline-based treatment for any acute or recurrent pericarditis. That usually means high-dose NSAIDs like ibuprofen or indomethacin combined with colchicine. If there's an infection involved, like that purulent pericarditis, then complete drainage of the infected fluid from the pericardial space. Pericardiocentesis is absolutely critical. You have to get rid of the source of that intense inflammation.
And what about for patients having heart surgery, operations where the pericardium gets opened?
That's another key area. For patients undergoing pericardiotomy, opening the pericardial sac during surgery, giving prophylactic colchicine afterwards, is now pretty standard practice. The thinking is that colchicine helps dampen down that intense inflammatory reaction that happens after surgery, reduces fibrin deposition, and therefore lessens the chance of scarring and adhesions forming later. By managing that early inflammation, you reduce the risk of post-pericardiotomy syndrome, which can sometimes then lead on to chronic CP.
Okay, back to the patient at the bedside. When a clinician starts suspecting CP, they're not just listening to the story. There are classic physical exam findings, right? The constriction signs, which are direct results of the mechanics we've been talking about.
That's right. The physical exam is focused on finding evidence of that high right atrial pressure and that dramatic ventricular interdependence. Probably the most common sign you'll see is marked jugular venous distension, JVD. Seeing those neck veins bulging confirms that backup of pressure in the systemic circulation.
And then you look for those specific clues related to breathing.
Exactly. You check for pulsus paradoxus. That's where the systolic blood pressure drops by more than 10 millimeters of mercury during inspiration. It's a direct result of those exaggerated restrictive volume shifts happening with each breath. And then, of course, the really famous one, Kussmaul's sign. Normally, your JVP should drop when you breathe in deeply, as the chest expansion helps suck blood into the heart. But in CP, that rigid pericardium prevents the heart from expanding to accept the extra blood. So instead, the JVP either fails to drop or it actually rises during inspiration.
That sign is just the perfect external manifestation of that pressure dissociation and the fixed volume issue we discussed.
It really is. The increased blood returning during inspiration literally has nowhere to go inside that fixed box, so the pressure just backs right up into the veins. And you mentioned earlier, this can sometimes have a liver counterpart. The enlarged liver might actually become visibly pulsatile or even feel like it gets bigger during inspiration because of that massive venous congestion hitting it.
And finally, there's that unique sound you can sometimes hear, the pericardial knock.
Ah yes, the knock. It's this characteristic high-pitched sound, usually heard best early in diastole, often along the lower left edge of the sternum. It's literally the sound of the rapidly filling ventricle suddenly hitting that rigid, non-compliant pericardial wall. Thud. It's the acoustic sign of that abrupt halt in filling. So you put these classic signs together, JVD, maybe Kussmaul's, maybe pulsus, the knock, along with the general signs like hepatomegaly, ascites, and bilateral leg edema, and that forms the clinical picture pointing towards CP.
But given that so many of those general signs, the JVD, the edema, the ascites, are just classic signs of heart failure in general, the differential diagnosis must be huge, and missing CP seems like a major pitfall.
It is absolutely the most challenging part in the clinic. You have to meticulously rule out conditions that can look exactly the same on the surface. The number one condition you have to differentiate it from is restrictive cardiomyopathy, RCM. That's where the heart muscle itself is stiff and non-compliant, preventing proper filling. But you also have to consider severe right heart failure from other causes, like pulmonary hypertension or severe tricuspid valve regurgitation. Even things like chronic liver disease causing ascites and edema, or severe COPD, or just simple chronic volume overload can sometimes mimic the picture. Without digging deeper for those specific dynamic features of CP, you risk misdiagnosing a potentially curable condition as CP as something often much less treatable, like advanced RCM.
Does lab work help much in sorting this out? Are there specific biomarkers?
Lab tests are definitely supportive, but they're generally non-specific for CP itself. We always check inflammatory markers, C-reactive protein, CRP, erythrocyte sedimentation rate, ESR. These are really important because if they're elevated, it suggests ongoing inflammation, which might steer you towards thinking about those potentially reversible, medically treatable forms of CP we discussed. Cardiac biomarkers, like BNP or troponin, will often be elevated too, just reflecting the stretch and strain on the heart muscle, but they don't reliably distinguish CP from RCM. Similarly, ECG findings like low-voltage QRS complexes or maybe atrial fibrillation are common in CP, but again, lots of other heart conditions can cause those too. So helpful clues, but not diagnostic on their own.
Okay, this brings us squarely into the imaging toolkit. This is where the modern diagnosis of CP really happens. And echocardiography, the ultrasound of the heart, is the essential first-line test. Why is echo still the go-to first step, even with fancier scans available?
Two main reasons: accessibility and, crucially, real-time dynamic visualization. Echo lets us watch the heart working, beat by beat, and most importantly, breath by breath. We can directly see the mechanical consequences of that rigid pericardium in action. Now, while seeing a thickened pericardium on echo, sometimes described as a rind-like appearance, is suggestive, you absolutely cannot rely on finding it. As the paper notes, something like 18% of patients who were proven to have CP at surgery actually had normal pericardial thickness on their scans. So, thickness isn't the main thing. It's all about the function.
Right, so you're relying on seeing those mechanical signs, especially those exaggerated breathing-related changes we talked about earlier.
Precisely. The echo finding that has the highest diagnostic sensitivity, meaning it's most likely to be present if CP is there, is that exaggerated respirophasic shift of the interventricular septum. When you clearly see that septum making a pronounced leftward jump the moment the patient inhales, and then shifting back sharply to the right when they exhale, you are literally watching ventricular interdependence play out. That's the heart fighting against its fixed volume constraint.
But doesn't the septum move a little bit with breathing normally? How do you get more specific to CP?
That's a great point. Yes, there's some normal respiratory variation. So to get more specific, we look at tissue Doppler measurements, how fast the heart muscle itself is moving. This is where we hunt for a sign called annulus reversus. This is one of the most specific non-invasive markers for CP. Normally, when the left ventricle fills, the outer edge, the lateral side of the mitral valve annulus, moves upwards faster than the inner edge, the medial or septal side. So normally the lateral EA velocity, that's the measure of this early diastolic movement, is higher than the septal EA velocity.
And in CP, this relationship flips. How does the constriction cause that specific reversal?
It's fascinating. In CP, the scarring and adhesions of the pericardium often preferentially tether or restrict the movement of the lateral wall of the left ventricle, and therefore the lateral part of the mitral annulus which is attached to it. However, the septum's movement might be relatively spared or even exaggerated because of that increased right ventricular filling pushing it over. So what you find is that the septal E velocity stays normal or even high, the paper suggests often 9 centimeters, while the usually higher lateral E velocity gets dragged down, restricted by the pericardial tethering. The result: the septal E velocity ends up being higher than the lateral E velocity. That reversal of the normal pattern is annulus reversus.
That's a brilliant detail. It shows how localized scarring can create this very specific measurable sign. And there's a similar concept using strain imaging, right? Sprain reverses.
Yes, it's basically the same physical principle, just measured differently using myocardial deformation or strain. We look at the ratio of how much the lateral wall of the LV deforms, strains, compared to how much the septum deforms. Normally, the lateral wall strains more. In CP, because the lateral wall is tethered, its strain is reduced. So you find a ratio of lateral LV strain to septal LV strains that's less than 1. The paper cites 0.96. Again, the lateral side is underperforming relative to the septa, the reverse of normal.
Okay, and what about the single most specific echo finding, the one related to that systemic venous backup?
That would likely be the excretory diastolic hepatic vein flow reversals. This looks at blood flow in the veins draining the liver. When a patient with CP breathes out, the constraint on the right heart becomes maximal, and that rigid pericardium causes a significant back pressure wave into the veins. If you measure the flow in the hepatic veins and find that during expiration, the velocity of the blood flowing backwards during diastole is very high compared to the forward flow specifically. If the ratio of that reversal velocity to the forward velocity is 0.79, that is highly specific for CP. You're seeing the pressure literally ramming blood back into the liver veins during expiration.
It's clear echo gives us the functional diagnosis. But you mentioned advanced imaging is often needed to refine things and guide therapy. Let's start with cardiac magnetic resonance, CMR.
Right. CMR is exceptional because it gives us two critical pieces of information that echo struggles with: really detailed tissue characterization and, importantly, assessment of inflammation. Anatomically, it's better than echo at visualizing the pericardial thickness itself and often shows where the thickening is worst frequently over the right ventricle and that groove between the right atrium and ventricle.
And this is where CMR directly helps make that crucial decision. Do we try medicine first, or is it straight to surgery?
This is arguably its killer application. CMR allows us to look for active inflammation within the thickened pericardium. If we see increased signal intensity on specific sequences called T2-weighted or T2-STIR images, that suggests there's edema, fluid, acute inflammation. Even more critically, we look for late gadolinium enhancement, LGE, after giving contrast. If the pericardium lights up brightly with LGE, it signifies ongoing fibroblast activity, new blood vessel formation, basically. It highlights the active construction site where scarring is currently being laid down.
So bright LGE means the scarring process is active, it's happening now, meaning anti-inflammatory drugs might actually be able to stop it.
Precisely. Finding significant LGE is a strong indicator that the patient is an excellent candidate for a trial of medical therapy. NSAIDs, colchicine, maybe even those IL-1 blockers we talked about, because it tells us the disease is still in a potentially reversible inflammatory phase. It strongly guides us away from recommending immediate high-risk surgery in those patients.
But CMR isn't perfect, especially for the really chronic burnt-out cases. It has a known limitation.
That's true. It doesn't image calcium well at all. And dense calcification is the hallmark of long-standing, fixed, chronic constrictive pericarditis. That's where cardiac computed tomography, CCT, really steps in.
CCT is the best tool for seeing calcium.
Absolutely. CCT is brilliant at visualizing pericardial calcifications. They often look like a dense white eggshell encasing the heart. Critically, CCT can also help us spot something even more ominous: intramyocardial fibrocalcitosis changes. This means the calcification hasn't just stayed in the pericardium, it has actually invaded into the heart muscle wall itself. Finding these intramyocardial changes is a serious red flag. It suggests that even if you surgically remove the pericardium, the constriction might persist because the muscle itself is now involved. It really limits the potential success of surgery.
So CCT basically tells the surgeon how bad the scarring is and whether the operation is likely to even work.
In essence, yes. But conversely, CCT is not good for evaluating diastolic function or seeing those subtle breath-by-breath septal movements. This is why in complex cases you really need multimodality imaging. It's not one size fits all. You use echo for the dynamics, CMR to look for inflammation and guide medical therapy, and CCT to assess calcification, anatomical extent, and surgical feasibility. It's often a three-pronged approach for a truly precise diagnosis.
Okay, so even with this incredible array of non-invasive tools, echo, CMR, CCT, sometimes the picture is still, well, murky. If the non-invasive data just isn't clear, or maybe it's conflicting, we have to turn to the cath lab, to cardiac catheterization. Why are invasive pressure measurements still sometimes considered the gold standard when things are ambiguous?
Because catheterization gives you definitive, simultaneous pressure readings from inside the different heart chambers. It offers a clear, quantifiable look at the heart's mechanics in real time. What we're looking for invasively is that definitive discordance, the undeniable mechanical signature of CP. This is best revealed by recording pressures from the right and left ventricles at the same time. In CP, you'll see the systolic pressure in the RV go up during inspiration, while the systolic pressure in the LV simultaneously goes down. That opposite movement confirms the enhanced ventricular interdependence.
Let's talk about those classic pressure waveforms you see in the cath lab, because they're so distinctive for constriction. The right atrial pressure tracing often shows that M or W pattern.
That's right. The M or W pattern is characterized by a couple of things. First, you often see a prominent A wave, which is the pressure rise from atrial contraction. But second, and perhaps more specific, is a very prominent and rapid diastolic Y descent. The Y descent represents the pressure dropping quickly in the atrium early in diastole as blood rushes out into the ventricle. Because that initial ventricular filling is so rapid and abrupt in CP, that Y descent becomes exaggeratedly steep and deep.
And that rapid rush of blood, immediately followed by the sudden stop against the rigid pericardium, that's what creates the classic ventricular pressure pattern.
Exactly. That's the dip and plateau sign, often called the square root sign in the literature because of its shape. What you see in the ventricular pressure tracing is a rapid drop early in diastole as the chamber fills aggressively. That's the dip. But then pressure abruptly rises and hits that rigid constraint and stays elevated throughout the rest of diastole. That's the plateau. It literally looks a bit like a square root symbol on the pressure tracing. Seeing that pattern is strong confirmation that the ventricle's filling is being mechanically restricted.
The cath lab is also where you can definitively confirm Kussmaul's sign, invasively.
Yes. The invasive proof of Kussmaul's is seeing that right atrial pressure actually increase, or at least fail to decrease, during inspiration when you're measuring it directly with the catheter. This definitively demonstrates that dissociation between the chest pressure and the heart pressure right there on the screen.
Now, let's talk about the really challenging cases, the ones termed occult CP. This is where all the baseline tests, maybe even the initial cath measurements, look frustratingly normal.
These are definitely the high-stakes scenarios. Occult CP often occurs in patients who have known risk factors, maybe prior radiation, maybe previous heart surgery, but their constriction is perhaps mild, or maybe they happen to be a bit volume depleted on the day of the test, which can mask the restrictive physiology. So their baseline pressures might look okay, but the underlying faulty mechanics are still there, just waiting to be revealed.
So, how do you ethically and safely try to unmask a potentially life-threatening condition that's hiding?
It involves using a carefully controlled, but yes, potentially high-risk, provocative maneuver in the cath lab. Rapid intravascular volume expansion. The standard way is to give the patient a liter, 1,000 milliliter, of normal saline intravenously, quite quickly, usually over about 6 to 8 minutes, while you are continuously monitoring those simultaneous right and left-sided heart pressures. If underlying constrictive physiology is present, that rapid fluid load will quickly overwhelm the heart's limited filling capacity, push it up against its fixed constraint, and suddenly unmask those characteristic findings. The diastolic pressure equalization, the discordance, the square root sign, even if they weren't there at baseline. It definitely requires a high index of suspicion to even consider doing it, and very careful monitoring and clinical judgment during the procedure.
Okay, let's turn finally to treatment. The review makes it clear that the management strategy is entirely guided by the stage of the disease. Is it acute, chronic, and critically, by that evidence of inflammation we get from CMR and labs?
That's right. We basically separate management into three broad categories. First, there's subacute or transient CP. This is the potentially reversible form. It might resolve on its own or more likely with medical therapy, usually within about 3 to 6 months.
And the key indicators here, what tells us this is likely transient and might respond to drugs?
Several things. The patient needs to be hemodynamically pretty stable. They shouldn't have extensive calcification visible on imaging. And crucially, they must show clear evidence of active inflammation. That means elevated inflammatory markers like ESR or CRP, or ideally that telltale late gadolinium enhancement, LGE, on their CMR scan. These signs tell you the disease process is still active and potentially amenable to anti-inflammatory treatment.
So, what's the medical trial for these patients?
First-line therapy is typically a course, often around 3 months, of a combination of a high-dose NSAID plus colchicine. If NSAIDs aren't suitable, maybe due to kidney issues or bleeding risk, or if there's a suspicion of an underlying autoimmune cause, sometimes a glucocorticoid like prednisone is used instead of the NSAID, but still usually combined with colchicine. The goal is aggressive anti-inflammation to halt the inflammatory process before it lays down permanent scar tissue.
But what if they don't respond to that first-line approach or they become dependent on steroids?
For those refractory cases, or patients who need prolonged steroids, we then escalate to the more powerful biologic agents, the interleukin-1, IL-1 blockers. These are drugs like anakinra or rilonacept, given by subcutaneous injection. The source specifically mentions the success seen in major clinical trials like AirTrip and Rhapsody with these agents. They work by blocking IL-1, which is a key cytokine driving inflammation and fibrosis in the pericardium. They've been shown to be very effective at shutting down the process in patients who are otherwise heading towards chronic, irreversible constriction.
Okay, next category is the kind of hybrid situation. Effusive constrictive pericarditis, effusive CP.
Right. This is where a patient presents with features suggesting subacute CP, but they also have a large pericardial effusion fluid buildup that's hemodynamically significant, often causing tamponade physiology. The key diagnostic step here is pericardiocentesis draining that excess fluid. The diagnosis of effusive constrictive is confirmed if, even after you've removed the fluid and relieved the tamponade, the right atrial pressure remains significantly elevated. Specifically, if it fails to drop by at least 50% or doesn't fall below 10 millimilli Hg.
So draining the fluid helped the immediate pressure from the effusion, but you're left with the underlying rigid shell still causing high pressures.
Exactly. The pericardiocentesis provides temporary relief from the tamponade component, but it reveals the underlying constriction. Treatment then follows similar lines. If there's evidence of inflammation, you'd give a trial of medical therapy. If the constriction persists despite that, or if there's no inflammation, then pericardiectomy might be required down the line.
And finally, the most severe end of the spectrum, chronic or persistent CP.
This is defined by symptoms lasting longer than 6 months. These patients typically present with those end-stage features we discussed. Anasarca, that's total body edema, significant liver dysfunction, often chronic atrial fibrillation, and usually extensive pericardial calcifications, easily visible on CCT scans. At this advanced stage, the potential space between the pericardial layers is often completely obliterated by scar tissue, and importantly, anti-inflammatory therapies are generally considered futile. The damage is done, the scarring is fixed.
So at this point, surgery pericardiectomy is really the only definitive cure left.
It is the only potential cure, yes. However, it is absolutely crucial to stress the gravity of this operation. Pericardiectomy is a highly complex, technically demanding, and high-risk surgery. Historical series, as mentioned in the review, have reported operative mortality rates as high as 18.6%, nearly 1 in 5 patients in some older reports. It is absolutely not a decision taken lightly.
Given that significant risk, who are the patients who are generally not considered candidates for surgery, even if they have chronic CP?
Meticulous patient selection is absolutely paramount. Surgery is often deemed too risky or unlikely to succeed in several situations. One is finding those extensive intramyocardial fibrocalcific changes on CCT, the disease has invaded the muscle. Another is evidence of very poor heart function before surgery, like a very low cardiac index. The paper mentions A 1.2 LMLN. Also, signs of profound cardiac cachexia, significant preoperative right ventricular dysfunction, severe underlying kidney disease, or significant COPD. All these factors increase the surgical risk dramatically and might make a patient unsuitable for pericardiectomy. For these non-surgical candidates, unfortunately, management becomes largely palliative, focused mainly on symptom control, especially managing fluid overload with high doses of diuretics, although this is ultimately just buying time. Hashtag outro video.
Wow. Okay, so this deep dive has really painted a vivid picture. Constrictive pericarditis is fundamentally about that mechanical restriction, that inflexible pericardium causing profound ventricular interdependence. But I think the key takeaway, especially thinking about the new millennium aspect, is this definite shift towards more precise, really tailored care.
I think that's exactly right. Modern imaging truly empowers us now in a way it didn't before. CMR lets us pinpoint active inflammation, which crucially opens the door for potential reversal with aggressive medical therapy. Then CCT quantifies the calcification and the extent of fibrosis, allowing us to much more accurately assess surgical risk and predict whether pericardiectomy actually has a reasonable chance of success. We've really moved beyond a historical situation where it felt like high-risk surgery was almost the default, toward a much more nuanced, highly individualized approach based on the specific patient's disease stage and characteristics.
Which brings us perfectly to our final provocative thought for you, our listener. Despite these incredible advances in non-invasive imaging that we've spent so much time discussing, the diagnosis of that tricky occult CP where the patient looks deceptively normal at rest still often hinges on intentionally provoking the system by rapidly overloading them with fluid during an invasive cath procedure.
And this really throws up a critical, clinical, and maybe even ethical challenge. How do we best identify those specific patients who look stable, maybe even feel okay, but who desperately need that potentially high-risk invasive fluid challenge to confirm their hidden constriction? Getting it right means we can intervene before they progress to severe, chronic, potentially fatal disease. Getting it wrong or missing it condemns them to that progression. It really highlights this continuous high-stakes balancing act that clinicians face, weighing the risks of an aggressive diagnostic procedure against the equally significant risks associated with letting the condition progress unchecked, potentially leading to an even higher risk surgery later on or becoming inoperable. It's a constant challenge.
Thank you for watching The Funnel Effect.